Morning, everyone, and welcome to our Thyro multidisciplinary seminar this morning. I hope everybody is settled in and excited about what I think will be a fantastic presentation. We do spend the vast majority of these seminars talking about care delivery and all the various nuances of dealing with both early stage and advanced stage disease in order to provide insight for clinicians. But this morning's presentation is really going to hone in on a different aspect of the patient experience. And I'm really thrilled to be able to introduce this morning's speaker, which is Dr. Christine O'Neill, who is an endocrine surgeon in New South Wales, Australia. So just if somebody's trying to calculate what time it is, it's close to midnight in Australia. She is a conjoint associate professor whose primary research is focused on patient-centered outcomes in endocrine surgery. She's currently completing a PhD in health-related quality of life outcomes in thyroid cancer. And in addition, she holds several other hats, including, or wears several other hats, including the Research and Scientific Officer for Australia, New Zealand endocrine surgeons. And she also serves as chair of the Hunter New England Endocrine Surgery multidisciplinary team and head of the Department of Surgery at John Hunter Hospital. This morning, we are also joined by one of my colleagues, Dr. Katherine Roberts, who obtained her master's in public health and a master's of science degree from Columbia University here in New York. And then I went on to complete a doctorate degree in health education, also from Columbia University. Her work focuses on quality of life, health promotion, and cancer prevention, control, and survivorship, all of which are extremely relevant to this morning's discussion. For over 20 years, Dr. Roberts has also taught biostatistics, research design, and health education in the Department of Health Studies and applied educational psychology at Teachers College of Columbia University, where she is an adjunct professor. Dr. Roberts is a master certified health education specialist, which I'm going to admit I don't know exactly what that means, as well as she is certified in public health, which I'm also not sure what that exactly means, but you can add that to her list of credentials. And I learned this morning that Dr. Roberts has completed her 22nd Ironman competition, which makes her incredibly well suited to be our discussant this morning here. So with that, as always, I encourage everybody to send in your questions. I will do my best. I've got a whole list of questions to add to the mix here, but we will certainly do our best to get to the questions from our audience. And so with that, I want to thank both Dr. O'Neill and Dr. Roberts for joining us here this morning. And Dr. O'Neill, why don't you go ahead and share your screen and get started?
So thank you very much for that kind introduction. I'm Chris O'Neill. Beyond my affiliations there, I have no disclosures. And funnily enough, today, or just today for you, almost yesterday for me now, was actually Australia Day. So I don't know whether you realize that when you invited me today, but today is a public holiday here in Australia. It's supposedly our national day. It is the middle of summer, so most people will spend that on the beach. And until a few years ago, everybody would wear Australian flags around or wear green and gold, which are our national colours, despite our flag being red, white and blue, that you'll get fireworks. But what today actually marks is the day that the first fleet arrived in Sydney with a boat full of convicts and invaded Australia. So it's increasingly become known as Invasion Day. And is quite potentially offensive to our Indigenous population and has really changed the way that we all think about the day and is changing the way that we celebrate the day. The landscape of thyroid cancer is changing significantly too, as we realise that patients are subject to significant potential overdiagnosis and hence potential overtreatment. Guidelines are advocating for de-escalated care for those with low-risk disease. And we increasingly realise that there are long-term health-related quality of life deficits in many of our patients for what we previously thought was an excellent cancer with very good outcomes. So our treatment decisions in the clinic with our individual patients now require us to understand the risk of the cancer that's being presented and its risk of recurrence, the treatment-related risks, and to talk all of that through with our patients and understand their values, and then together with them to make a holistic decision about long-term outcomes that's likely to lead them to optimised well-being. So we're really in an era of individualised treatment. And just to illustrate this plague of overdiagnosis, this graph on the right here, if you unpack it, I've put in red the North American and Australian and New Zealand graphs, but there's a little dotted line here which follows up the expected diagnoses, and the grey, light purple and then darker purple lines are above are the overdiagnoses. So in Australia, approximately 70% of thyroid cancers are said to be overdiagnosed, but we actually have less of a problem than many other countries around the world. Most of these overdiagnoses are middle-aged women, and these people are hence labelled as cancer survivors and have the potential for overtreatment. Of course, we all know that in real life, it's very hard to know with the patient in front of you who is that's overdiagnosed and who has the early detection. I first became really interested in all this health-related quality of life in thyroid cancer when Cord Sturgeon came out to our Australian and New Zealand meeting in 2018 and showed us some of his benchmarking data. This is not his, but showing that thyroid cancer survivors have poor quality of life compared to survivors of other cancers, in particular breast cancer and colon cancer, where the survival is inferior and the aesthetic and physical challenges are higher. And if you dig a little further, a lot of this is because of psychological issues with anxiety, depression, and fatigue, and perhaps less so with physical functioning. And worldwide, there's an increasing amount of data and publications and presentations showing deficits in long-term quality of life in patients with thyroid cancer. There's been multiple studies out of Sweden, studies out of England and other centres in Europe, studies from China, from Korea and Japan, particularly in microcarcinoma. And we also published the first long-term study from Australia last year showing long-term deficits in our population as well. Beyond global quality of life, there are specific issues that these patients face in terms of financial burden or financial toxicity and fear of cancer recurrence or cancer-related worry, which it can be a significant driver of poor quality of life outcomes. But when you unpack a lot of this data and look at the survey data and use the patient-reported outcome measures, it really generates, for me at least, more questions than answers. So a lot of the surveys will use generic surveys, things like SF36 or PROMIS or EQ5D5L. And whilst these allow you comparison to the normative population and perhaps cost utility analysis, they don't ask the nuances of thyroid cancer survivors. To find out information about thyroxine, hypothyroid symptoms, calcium deficiency, voice or scarring, you need to use a thyroid cancer specific survey, such as THYCA, Thy34 or the City of Hope thyroid version. And even if you put those two together, most of them will not comprehensively cover issues like fear of cancer recurrence and financial toxicity. A number of the studies in the published literature has also recruited patients from supportive care groups online, and hence these studies are subject to potential selection bias. Surveys have been done in different languages and different populations, and there's a variation into validation. In fact, you could probably run a whole webinar on what validation actually means in these groups, but whether it's valid to compare across those is up for discussion. Not all surveys assess all domains of health-related quality of life. Physical and psychological domains are frequently covered, but social and spiritual domains are not. And at the end of the day, even if you cover all of that, we still might be missing some things that are important to some patients. And this is where qualitative data becomes important, because for us to ask and assume that we ask survey questions, we assume that we know all the questions to ask and we know the emphasis for those questions. Whereas to ask the patients themselves directly in a less structured way, without that preconceived structure, allows them to air their concerns in their own voice and with their own emphasis. So with that in mind, and on the basis of a literature review and learnings from our prior study, we designed a mixed methods study looking at comparing different survey tools, measuring the acceptability and comprehensibility of those surveys within a thyroid cancer population, and also adding a qualitative element with interviews to ensure that we understood the breadth and depth of thyroid cancer survivorship. The prompts were repeated over 4 time points over the first 12 months following the diagnosis of thyroid cancer, and we attempted to recruit all patients from our geographic base who had a new diagnosis of thyroid cancer. These are the prompts that we're using in the study. We have 2 thyroid cancer specific tools, City of Hope and ThyCar. Thy34 was not validated at the time we started this study. EORTC QLQ-C30, which is a cancer-specific survey used frequently in mixed oncology populations. SF12, which is a short version of SF36. Assessment of Survivor Concern Scale, which is a 5-item fear of cancer recurrence scale. PHQ-4, which is an anxiety and depression screener, and a financial toxicity scale. We started recruitment for this study in February 2020. And then encountered a pandemic, which changed our entire pattern of healthcare delivery and led us to telehealth. Despite designing our study based on recruitment strategies that were published in other studies, we had very poor recruitment for 2020, and we ended up revamping our recruitment and starting afresh in January 2021. We've attempted to collect all patients with a new diagnosis of thyroid cancer who are presented through our regional MDT, which does present all new diagnoses. We excluded anaplastic and micropapillary thyroid cancer without adverse features. And we excluded patients with poor English or lacking capacity to answer prompts, although the number of patients excluded for that reason was less than 10. We've now closed to recruitment, but we'll continue to collect our prompts out until the middle of this year. We've completed baseline data for almost 100 patients with a 50 to 60% response rate. And the interview component is the subject of today's webinar, and we'll talk about that. But before I do, I just want to talk about the context in which I live, because healthcare delivery in Australia is different to some other places in the world. I live in Newcastle, which is a coastal city about 160 kilometres or 100 miles north of Sydney. But the area that we cover has a population of about 1 million people, but a size of Alabama or Louisiana or of England. So it's geographically sparse and contains patients from metropolitan, regional and rural areas. Within that geography, there's the town I live in, which is famous for its surfing beaches and very large ocean pools. Up the road is the Hunter Valley, which is famous for wines, horse stud, and very large open-cut coal mines. And further up the road are very large farms with sheep, wheat, beef, and Tamworth, which has hosts Australia's largest country music festival. In the clinical context, Australia has universal health coverage, but that is provided through our public system. Approximately 40 to 50% of the population is privately insured and has access to the private hospital system, and so there are significant disparities in care between public and private patients. Most surgeons, including myself, work across both sectors and hence across multiple sites. Our MDT structure or tumour board structure is virtual, and by doing that we can cover our geography. All the surgeons who perform thyroid cancer surgery in our district are high volume surgeons, either in metropolitan areas or in regional centres. Most patients do not travel long distances to receive care, although a long distance in Australia is a lot further than it is in many other countries. We also have a restrictive biopsy protocol for nodules less than 1 centimetre, and most of our follow-up is centralised and done by endocrinologists who perform their own clinician-performed ultrasound. So having spent that time on context, I'll now turn to the paper for discussion today, which is our interviews paper. So we developed the script following a review of the literature, and the interviews themselves were undertaken by one of two female trained research assistants, each of whom had more than a year of full-time experience in patient-centered interviews. Consent was recorded, ethics was obtained. We piloted the interview script with 8 thyroid cancer survivors who were diagnosed prior to our wider PROM study. We analysed and coded those scripts and did not make any meaningful changes to the interview script. And so we included those 8 interviews in the further analysis, in the analysis, and undertook another 14 interviews. We aimed for a maximum variation sample with respect to age, gender, geographical location, tumour stage. The patients from those 14 interviews were all diagnosed in 2021, and their interviews occurred 6 to 12 months after their diagnosis. The interview script was designed to be broad and to ask patients to express in their own words what their thyroid cancer survivorship experience had been. But within that, we included prompts to ensure that we explored the impact of thyroid cancer diagnosis on their finances, emotions, fear of cancer recurrence, their impacts on their family and social interactions, employment and daily activities, and also look at information and support structures that patients had been able to access. The data, the interviews were recorded and transcribed verbatim. They were coded by 2 investigators, one of them myself and the other one with a background in sociology. We used a hybrid and inductive realistic codebook thematic analysis as described by Braun and Clark, developed codes, categories and themes, and retested these against the data. We deemed the data of sufficient depth and breadth after 16 interviews and used in vivo for data management. These are the demographics of our patients who were interviewed. The median age was 54, slightly more women, slightly more privately insured, but otherwise a relatively even match of geography, educational status. Interviews ranged from 20 minutes to 66 minutes, although the majority were around 45. The disease characteristics, most of these patients had low risk papillary thyroid cancer, about half hemithyroidectomy and total thyroidectomy. But there were 2 patients in this study who had high risk stage 4 disease who were on lenvatinib at the time of the interview. So after our analysis, we came up with 3 themes. The first, the impact of diagnosis and treatment. The second, thyroid cancer doesn't happen in isolation. And the third, the role of the clinicians and formalised support structures. So before I start, I want to invite you to read these quotes and to pretend that they're coming from your own patients in your own accents, not my Australian accent, because these are the words of patients, although they don't represent all patients. When I presented this to my own MDT, I was careful to tell them that some of the comments were complimentary, but some of them might challenge them in terms of feedback from their own patients. And I challenge you to join with us the process of qualitative research, which involves putting aside your prior assumptions and trying to listen just to what is being said from these patients. And you'll see that each quote is contextualized with the patient's gender, age, and ATA risk score. So our first theme, impact of diagnosis and treatment. The term cancer really did shock a lot of patients due to their prior associations with cancer-related death, with treatment-related side effects from chemotherapy and radiation. But their subsequent reality of their experience left many feeling lucky because their experience was very different to their prior association of that. Some, though, expressed that they felt that doctors lacked empathy for them being diagnosed as a cancer and dismissed their concerns as being a cancer survivor. Some of these concerns, when asked about the impact of a cancer diagnosis, many of these patients denied any impacts initially, but it didn't take a lot more probing to start to uncover issues about fear of cancer recurrence or a change in life perspective or locus of control for these patients, which had ongoing impacts throughout their social life. We specifically asked about clinical follow-up and what patients felt about it. Patients most patients reported that appointments were worrying in the lead up to them, but ultimately reassuring to know that their cancer had not returned. But some patients would have preferred to never have another appointment, and that would have been better for their psychological well-being. Some patients reflected that follow-ups were just about their physical health, scans, and blood tests, and not about emotional or psychological well-being. Of course, this study was undertaken during restrictions for the COVID-19 pandemic, which Australia had some of the longest running restrictions in the world. Access to care was difficult for particularly public patients at that stage, also for rural and uninsured patients. But for some private patients, access to care was incredibly expedited, and they almost felt taken aback a little by how quickly their cancer surgery was undertaken. The impact of telehealth consultations was also significant, with many patients reporting that they did not get the same reassurance or information from a telehealth consultation as they would have done from a face-to-face consultation. Many patients had prolonged symptoms following their surgery that interfered with their return to activities far longer than they had anticipated from the information they'd been given preoperatively. Patients commented that often when they raised these with their clinicians, that these concerns were dismissed, minimised, or unacknowledged. Particularly for patients who had had issues previously with weight gain, changes in weight were very distressing. Patients who had voice change found this quite distressing until their voice returned. Or for occasional patients who had prolonged voice change, there were a couple of patients with recurrent laryngeal nerve sacrifice in this study. They had ongoing significant issues with their voice, although did receive significant care for that. Patients reported changes in cognition, in motivation, and inability to organise themselves, which affected their return to work and social activities. And a number of patients struggled with thyroxine titration and felt dismissed by their clinicians when asking to be involved and to self-help with their own titration. Patients who, particularly young female patients, had issues with fertility, and despite having physical checks and advice regarding not getting pregnant after radioactive iodine, this was insufficient to reassure them, and they were left with unanswered questions. Our second theme, thyroid cancer doesn't happen in isolation. We all know that we all have our own family commitments, social commitments, our own work places, and that a diagnosis of cancer doesn't happen outside of these. So for some patients, they had significant family stressors at the time of their cancer diagnosis. Patients with children really struggled to explain to their children what was happening and the isolation that was required for radioactive iodine treatment. Patients in employment, some of them had great support from their workplaces. Others tried to return to work after they were physically healed from their surgery, but found that they just weren't quite ready to return. Other people struggled to re-enter the workforce because of discrimination based on a cancer diagnosis. Most patients denied financial concerns when initially asked, although they did admit to some out-of-pocket expenses, which were worse for those that had to travel or for those who had lost employment either as a result of their thyroid cancer diagnosis or due to its coincident timing with the pandemic. We explored coping strategies. Many patients drew on prior life experiences for their coping strategies, and using a positive outlook, avoidance and distraction were the common strategies. Most used their pre-existing support networks for support and commented that they did not need other formal support when it was offered. Some people tried to normalise their experience for their support networks, however. And our final theme, role of clinicians and formal support structures. Patients derive significant reassurance from their clinicians and support. They really appreciated clinicians who checked in with them emotionally and allowed them to voice their concerns. And patients that felt informed and shared in their decision-making reported less psychosocial concerns. Information seemed to be adequate, particularly around surgery, to some extent around radioactive iodine and other treatments. But subsequently, about longer-term effects and return to work and psychosocial concerns, patients reported a lack of information, a lack of ability to reach out for supportive care, and a lack of ability for care navigation. Timing of information was also an issue, as although it was provided initially, many patients felt that that was not the right time and they were left with unanswered questions subsequently. Some of them days later, some of them months later. Information gaps included long-term effects of thyroxine, body changes, and how much of this was due to their thyroid cancer. Some turned to online social media for answers to their questions. Formal support structures were lacking. They were either unavailable, unable to be accessed, or inappropriate. Patients did try to see psychologists, but couldn't access them because of wait lists. And the timing of supports when it was offered was not appropriate, as it was needed months after the initial diagnosis and not necessarily at the time. So finally, to bring it all together, the main findings of our study were actually that there's significant variation in experiences, but that it's very important to acknowledge patient concerns and to be realistic with them about full return to work and social activities. Patients' recovery is very individual, and there's a need to individualise care not just on disease characteristics, but also on patient characteristics and values. And patients find incredible support informally from their clinicians, but some of them may require formal supportive care as well. So at the time of diagnosis, we should all be aware as clinicians that the word cancer evokes a very strong emotional response, and that the term of a good cancer is often quite dismissive. I can't emphasize enough that patients derive significant reassurance from their healthcare providers, that information is empowering, and that patients appreciate being involved in their treatment decisions. Care navigation in our population was lacking. Beyond treatment, patients needed their persisting symptoms to be acknowledged, and they appreciate, not beyond acknowledgement, being directed to ways that they might be able to self-help, as this is empowering and assists with their recovery of those symptoms. In terms of follow-up, we should consider whether follow-up is truly necessary, and if it is, ensure that it is addressing patients' psychological and emotional well-being as well as their physical well-being. Patients really value emotional check-ins and trusted their clinicians who address their psychosocial concerns. Formal supportive care needs to be available for those who need it. In our population, there were no pathways for this in questions subsequently. Interestingly, fear of cancer recurrence was not as prominent in our study as it's been previously reported, but it is known to be a significant driver for discussions around the extent of surgery. And in the wider oncology literature, there's starting to be fear of cancer recurrence screening and even clinician-led interventions brought into follow-up care. For patients with mild or to moderate fear of cancer recurrence, normalization and clinician-led mindfulness sessions, which can be done in only a few minutes, can be very powerful. For those with more severe fear of cancer recurrence, more formalised referral pathways are needed. Our study had limitations like all. We admit that no sample can capture all the views of patients. We did not include any patients with medullary thyroid cancer or who underwent active surveillance in our cohort, and we acknowledge that demographic concordance can influence patient responses, but we attempted to diversify the background of our research team to address that. For us, where to next? Well, we are still finalising data collection and analysis from our aligned PROM study. We're already developing shared decision-making resources, including a hybrid paper and web-based decision aid aimed at being used in clinical practice for those with low-risk thyroid cancer to assist them in making decisions regarding the extent of surgery. We realise we need to work on interventions and care navigations for those requiring supportive care, and we're really interested in wider collaboration, particularly internationally. But as a final word, I want to challenge us as clinicians who see patients every day to think about what we can do to help our patients in their thyroid cancer survivor journey. And I can't emphasize enough how much clinical encounters provide support to patients beyond physical care. Simply acknowledging patients' distress, symptoms, emotionally checking in can be very powerful in reassuring patients and may provide significant supportive care and avoid the need for formalised support services. It's also important to provide information resources and to try and screen patients who might need more formalised support and refer them as required. So finally, I'd just like to thank the members of my research team, in particular, Chris Rowe, who's an endocrinologist, Chris Paul, Liz Fraggley, and Mel Carlson, who are behavioural science researchers. And I'd be happy to take questions and discuss this further and receive emails if anyone would like to reach out. So thank you very much.
Okay. I am up. So good morning, everyone. Thank you for having me discuss this interesting and important topic. Thank you, Dr. O'Neill, for the wonderful presentation and the review of your article. As Dr. Erkin mentioned, I am not a medical doctor. Instead, I have a doctorate in health education and focus on the practical application of research in the field of public health and healthcare. I often work to bridge the gap between research findings and the real-world implementation. I have no disclosure. So there have been many studies looking at health-related quality of life outcomes. And as we just heard, there are many different survey tools that have been used. In this study that Dr. O'Neill presented on, a different method was used. As we just heard, interviews were conducted with thyroid cancer survivors, allowing them to freely express their experiences and priorities. The reason why this is important is because different methods can provide different perspectives on the same issues. Interviews can offer in-depth insight and personal experiences that quantitative data collected from surveys may miss. So we have known about thyroid cancer survivors' unmet needs for quite a while now. For example, this study is the one we conducted over 15 years ago, and we found some similar unmet needs. We surveyed thyroid cancer survivors and found that they also worried about cancer recurrence. They wanted information about lifestyle factors that might affect the risk of recurrence, and they wanted to continue to be updated with information and education pertaining to thyroid cancer. Over the past 15 years, there have been many more studies on thyroid cancer survivors' unmet needs. But as discussed, most of them do collect quantitative data from surveys. It is helpful to have different methods, such as interviews, that confirm similar findings. It enhances the credibility and reliability of the data. Regarding the impact and management of health-related quality of life, which is a multidimensional concept that encompasses physical, emotional, social, spiritual, and cognitive functioning, what do we know? Well, we know that the impact of thyroid cancer on health-related quality of life can be significant. This impact, including the psychosocial impact of thyroid cancer, has been recognized in the field. We know that thyroid cancer survivors have unmet needs, and addressing these needs can improve coping, adjustment, and overall well-being. We know that they have unmet needs, so how do we address them? These are just some examples. We can provide local resources such as local social workers, psychologists, nutritionists, local support groups. We have online support groups and many thyroid cancer specific resources available, and they keep increasing. So these next slides are just a few examples, which many of you are well aware of. One of the most well-known online support groups, Thyroid Cancer Survivors Association, has been around since 1995 and has developed a network of services that link thyroid cancer survivors and healthcare professionals. They maintain current information about thyroid cancer and support services available to people at any stage of testing, treatment, and monitoring for thyroid cancer, as well as their caregivers. And they provide a lot of information and provide support groups that are free and available to survivors and their families and friends. Cancer Care, which was founded 80 years ago in 1944, provides free professional support services and information to help people manage the emotional, practical, and financial challenges of cancer. And ASCO, the American Society for Clinical Oncology, brings the expertise and resources of cancer physicians to people with cancer or who have experienced cancer and those who care about them. They provide resources to help better cope with cancer. And of course, we have the wonderful Thank Guide, which provides knowledge, hope, and support. So as you can see, there is a wide array of resources available, but they are not necessarily tailored to individual needs. This may be particularly important, especially since there are at-risk groups who experience greater psychosocial impact. This includes adolescents and young adults who have shown to have worse scores on functional domains such as physical, role, social, and cognitive functioning, and symptom scores. In this study that is shown on the slide, Stephanie Smith and colleagues interviewed young people ranging from 19 to 34 years old. It was an exploratory study with a small sample size of just 8 individuals, but it also collected qualitative data through interviews. They also found that there was a strong emotional impact of being diagnosed and treated for thyroid cancer, and these individuals were working towards making sense and coping with this experience. The authors also found that there was a need to identify with others who had experienced thyroid cancer. Thyroid cancer support groups could be beneficial, especially if they are able to communicate with others their age. Providing information that was readily available and appropriate to these young people's needs can be particularly helpful, including emphasizing follow-up care and psychosocial aspect of managing thyroid cancer. Other groups that may benefit from tailored information are patients with comorbidities, such as those with diabetes or those with mental health conditions, such as anxiety and depression, which is associated with lower quality of life. Additionally, in thyroid cancer survivors with favorable prognoses, cancer-related worry is especially evident in female patients, younger patients, those with lower education, and racial and ethnic minorities. Therefore, these groups may need additional support and culturally sensitive targeted interventions. We need to continue to design and tailor innovative management options to provide support. But the question is, who is responsible for this and for providing these supports? Psychosocial support is typically provided by a multidisciplinary team, each offering their unique expertise to address the various emotional, social, and psychological challenges that patients may face. Key members of the support team often include the clinician, which we just heard about. As Dr. O'Neill discussed, many participants express significant trust in and rapport with clinicians. However, these individuals may not be the most ideal healthcare member to provide information and support to patients for several reasons, including time constraints, and they have specialized knowledge in medical diagnosis and treatment, but they may not have the knowledge or training in areas of patient education, consulting, or social support services. Some clinicians may have a more clinical or technical communication style, which might not be as effective for providing emotional support or explaining complex medical information in an easy, understandable way. Other members of the healthcare team, such as nurses, patient educators, and mental health professionals, including social workers, psychologists, and counselors, often have more training and experience in providing holistic, patient-centered care. And there are many others that provide support, actually too many to put on this slide. But for example, cancer case managers can advocate for patients' needs and preferences, provide psychosocial support, and provide assistance in assessing appropriate resources. There are community organizations that work closely with medical profession to ensure the needs of cancer patients are met. And then there's these private businesses that can also engage in activities that support cancer patients, similar to those provided by community organizations and cancer care managers. And then there's even AI, which has already shown some promise. AI can provide educational resources and emotional support through chat bots and virtual assistants. On a related note, we have to be mindful of the method in which these supports are provided. As Dr. O'Neill discussed, telehealth consultations failed to provide as much in-depth information and reassurance as face-to-face consultations. Therefore, it is essential to carefully consider and optimize the delivery method of supports to ensure they are effectively meeting the needs of individual patients. The frequency and timing of providing psychosocial supports can vary greatly depending on individual needs, the context of the situation, and the type of support being provided. Ideally, the timing of the psychosocial support should be tailored to the individual. However, as Dr. O'Neill discussed, clinical follow-ups can provide an opportunity for psychosocial support. Do we provide these supports every time there's a clinical follow-up, or do we provide them more frequently? Also, do we provide support when pertinent new information is available? And if so, how often? So there are many other areas to explore of this topic, and we can have an entire discussion on the ideal delivery method and when do patients best comprehend information, how readable and understandable are patient education materials. But in the essence of time, we can end. And in closing, I just want to say that today's presentation underscores the importance of addressing the diverse and multifaceted needs of thyroid cancer survivors. From Dr. O'Neill's insightful study, we gained a better understanding of the need to provide empathetic, individualized support that addresses not only the physical, but also the emotional and social challenges faced by thyroid cancer survivors. There are a range of resources from local healthcare providers to online platforms, which can offer valuable information and support. However, we're reminded of the necessity for these resources to be tailored to the unique experiences of individuals, particularly vulnerable groups. By continuing to adapt and innovate our support strategies, we can make significant strides in improving the quality of life for thyroid cancer survivors. So thank you.
Awesome. Thanks so much, Katie. Thank you so much, Christine. Let me just, I've got, there's so much to unpack here. I've got so many questions I'd like to get into, and both of you can certainly provide some insights for, what I think will be mostly clinicians who will be listening to us today and in the weeks that follow here. One interesting thing was the time frame in which this study was conducted. And so, Christine, can you maybe comment? This was a unique time and in the history of the universe, and with respect to this overarching concern about COVID as another illness that we were all vulnerable to and continue to be vulnerable to. How do you think that impacted either the study, not so much with respect to access to healthcare professionals, but in terms of how physicians were interacting with patients about this other diagnosis that you studied, but also how patients were responding to the survey?
Yeah, I think the COVID experience in Australia, I think, was quite different. We actually had very strict restrictions on movement, and hence the majority of the population did not actually get COVID until they were fully vaccinated. And so our actual disease outcomes from COVID were, and the deaths from COVID were actually quite lower compared to many other places in the world. So whilst there was some fear about kind of contracting COVID, the actual number of cases was not actually that high at any particular point in time during this study. It was actually more the impact of restrictions on movement and actually restrictions on surgery. So there were many months where we were actually only allowed to do cancer surgery and not allowed to do non-cancer surgery, which perhaps contributed to some cancer patients getting even faster care than they normally would. So it kind of worked in ways that you wouldn't necessarily think. Some patients actually benefited in return to work because they had flexible work and were working from home where they would not have done otherwise. So I acknowledge it was a very unique time, but we actually had a period of a number of months towards the end of 2021 where we had no COVID in Australia. We eradicated it from the country and we went back to normal. So it was interesting, but probably a different play out, I think.
Great. Let me ask you, do you, and Katie, you may have insights into this. Did you identify any differences between male and female responders? And also, what was that you had two female investigators performing the surveys, and was there any anticipated difference or any identified difference with respect to same-sex versus opposite-sex interviews and how that may have played out here?
I mean, I think demographic concordance goes beyond just gender. It goes to age. Some people will find educational relations with people, and we all know that sometimes we just find it easier to chat to certain people than we do to others. Except we didn't have a male behavioral scientist interviewer, but there's only so many research assistants that you can access.
Okay, Katie, how do you? Yeah.
I actually was wondering, you had 8 thyroid cancer survivors who were either 1 to 20 years after diagnosis, and then you had these 12 patients who were newly diagnosed within 6 to 12 months following diagnosis. So I was just wondering, did you see any differences? Or I know it's a small sample size, but it would be interesting to see, especially if they're really the difference between someone who's 20 years out compared to someone who's just newly diagnosed.
Yeah, yes, to some extent, although they actually were surprisingly similar issues. They still had fear of cancer recurrence and still felt like they had quite strong emotional and psychological responses to their cancer diagnosis and to recalling the treatment process even many, many years down the track. So the themes were actually quite similar between the two groups.
Interesting. So we've come to understand quite a bit, especially in dealing with very low risk thyroid cancer, about patients' concerns that weigh on their decision regarding undergoing immediate surgery versus active surveillance. And we've all heard about minimalists versus maximalists in terms of care. But I'm just wondering, is there a way for us to better understand the needs of the patient at the very outset of the journey, to the extent that we can tailor that, not just their initial, but also their downstream care needs and psychological needs? It seems like there's, in my simplistic surgical brain, I feel like there must be some way that we can categorize patients more accurately, so that we know that there's a group of patients who are going to have greater challenges and greater impact versus those that will not. Can you maybe both of you talk about that?
Well, I think I suspect it would be too much to unpack both issues in the initial consultation, and you might need to separate the initial discussions to the later on ones, although I agree they're related. I think some of the resources that we're developing are trying to actually get patients to understand and answer questions on an interactive website about how they feel about their cancer coming back, how they feel about having potentially a second operation, how they feel about potentially not having their cancer removed, and to try and unpack that slightly separate from the decision about surgery, or how they feel about being on tablets. So we've actually recently done a discrete choice experiment looking at how patients value those sorts of risks in terms of decision making, and trying to help patients. I think it's one thing to ask them those questions. It's another thing when you're face to face with those questions to unpack that in the clinic and to try and pull out from the patients what they value most and to integrate that into your decisions.
Absolutely. I would completely agree. It would be wonderful if they could come in and they could either fill out, a psychological measures, or discuss with others what their preferences are, as well as get to their underlying conditions or underlying worries. And so we could match what they're feeling with some of the resources that are out there. Because I agree, if you just go out there and say, okay, here's all the resources, here's the support, we know exactly what you need, that actually could backfire. And they would say, you know what, that's not me, and these are not appropriate. And they could actually feel, not heard. And so we want to avoid that. But it would be wonderful if we could come up with some kind of measure where they would be able to fill it out, and then we could, match.
Right. So do you both feel that the treating clinicians, you comment on this, but are the treating clinicians the ones that, because of having built that relationship already in the initial stage of care, are they the best people to address the concerns and well-being of the patient? Or is that something that would be better served by someone who's not part of the initial treating team here? Either one, yeah.
I think it depends. I think we have to all acknowledge our own strengths. I'm a surgeon, you're a surgeon. We hope that we have many strengths, a lot of which don't involve talking to patients, but involve operating on them. So I think though you're right, you have a relationship with the patient, and at the very least being able to check in with them and screen them for psychosocial concerns would be very helpful, I think. But beyond perhaps brief interventions, which some people may be more amenable to or better at delivering than others, probably if there's real formalized supportive care needed, that's probably better done by others.
Yeah, absolutely.
Do you agree, Katie?
Yeah, absolutely. That was actually what I was discussing, is that, they're not highly trained in this area, and there's so many other team members that are, and we do need, and they can develop similar relationships with the patients. So I don't think it should all rest on clinicians' shoulders. Instead, they should say there are a lot of team members and try to develop that relationship between the patient and those.
I think that normalization of those issues is very important too. So I think normalizing that having a cancer diagnosis does cause an emotional response, and that a lot of people do need help, and then perhaps people don't feel so bad about asking for it.
Absolutely. And then if we can, build that relationship and they follow up, maybe they won't have some of that worry or stress or anxiety that, even you demonstrated in your study with these follow-up calls. So it could be something that, occurs monthly or whenever they want. So some patients want a lot of information and some don't want so much information. So we have to take that into consideration as well.
I often wonder about the inherent bias that the clinician brings into the room with them. And so I noticed that the majority of follow-up care in Australia is done by endocrinologists, and endocrinologists don't have as much experience dealing with cancer diagnoses because of all the entire range of endocrine disorders that they need to treat. As opposed to surgeons who may have that experience much more frequently, but also bring in baggage of treating more advanced cancers, other cancers with greater life risk, life-threatening conditions, and how that impacts the interaction with patients and with respect to perhaps trying to minimize what the impact of a thyroid cancer diagnosis is compared to the patient next door who is going to have to lose their larynx or part of their jaw and whatever. As those are the kind of the real life altering types of diagnoses. So what are we missing in terms of training physicians who are involved in the care of cancer patients? Where do you think we should take that? Because that's really not a part. We train as surgeons, we train people how to care, how to deliver surgical care, how to make decisions. Medical people deal with all the other aspects as well. So what should we be doing in order to address the needs of the patient in the education of our treating physicians? That's a lot to unpack. We've got another hour to go here. Either one of you, if you want to address that.
I mean, I can't speak for the whole of medical education, but I think that at the end of the day, we all went into medicine or surgery or whatever we did because we wanted to help patients and make the right decisions. And if that also includes communicating well with them and helping to respect their values. And maybe we need to be trained well to do that.
Yeah, and you also have to understand that you're not out there alone on an island, right? So there's so many people and others who have expertise in providing even reassurance and support, and it may not be you. So I do think we have to bring in and develop these systems where we can provide, other people can provide some of these supports. And it's hard to conceptualize, like, what does that entail? Does that entail having a patient go to, these X, Y, and Z individuals, or can we tailor that to their preferences? But, you do have to understand that you're just not alone out there. There's a lot behind and who really support and can communicate well with the patient.
Awesome. That's an incredibly important final endpoint to this discussion, a discussion that I'm sure we will learn a whole lot more about as further research is done here. Unfortunately, we are up against the 9 a.m. here in New York, so we will have to end this discussion at this point, but I want to thank both Christine and Katie for just an outstanding presentation this morning, and certainly encourage all of our listeners to send in questions or comments that we can direct to both of them if you'd like to. So once again, thank you for joining us. We will be back next week, and hope everybody stays safe. Take care now.